Okay, good afternoon, everyone. Welcome to Medical Grand Rounds. Today, I have the pleasure of introducing to you Dr. Susan Calcaterra. Uh, Dr. Calcaterra is an assistant professor of medicine who's also appointed in family medicine as well as psychiatry. She's the director of the Addiction Medicine Consult Service and the associate director of the Addiction Medicine Fellowship. I'll say a few more words about Dr. Calcaterra in just a minute. However, I want all of you to know that there'll be time for discussion at the end of Dr. Calcaterra's talk. Please submit your questions into the Q&A question box, and with the help of the medical chief residents, I will moderate a discussion at the end of Dr. Calcaterra's talk. Dr. Calcaterra received her bachelor's degree from the University of Michigan, went on to get a master's as well as an MD degree at Wayne State School of Medicine, and received an MPH in epidemiology from the University of Colorado School of Public Health. She did her internship, residency, primary care fellowship, as well as addiction medicine fellowship at the University of Colorado, and has recently received a KOA mentored award from the National Institute of Drug Abuse. This award focuses on barriers to integrate opioid use disorders in the treatment setting, such as the inpatient services, which you'll hear more about. Dr. Calcaterra is also interested in how addiction has affected inmates, as well as how addiction has had profound effects on our general society. So very broad-ranging interests and a very important area of investigation as well as clinical activities. She's received numerous awards and honors, including induction into the Gold Humanism Honor Society, and has received the Toby and Mort Mower Visiting Scholarship, which she used to travel to Ben Gurion University and work with investigators at Ben Gurion University. So it's a pleasure to have Dr. Calcaterra talk with us about destigmatizing addiction. I'll turn it over to her right now.
Thank you, Dr. Schwartz, for the introduction. Today's talk will provide a more in-depth detail regarding current management of alcohol withdrawal and alcohol use disorder. The talk is informed by the Clinical Practice Guideline on Alcohol Withdrawal Management, which was published on behalf of the American Society of Addiction Medicine in January of 2020. So I'd like to start by saying I have no personal financial relationships with commercial interests relevant to this presentation. I will mention several FDA-approved products, and I am currently funded on a National Institute on Drug Abuse KOA award, and the opinions expressed here in this talk are my own. There are 3 learning objectives for this talk. First, I'd like you to learn to recognize which patients are at highest risk for developing severe alcohol withdrawal. Next, be able to describe various medications and treatment practices for alcohol withdrawal management. And third, be able to describe various medications for the treatment of alcohol use disorder. So let's start with a case. Mr. Smith is a 48-year-old man who's in the ED with a minor head laceration that occurred after he fell while intoxicated. He's A&O ×3 and looks well. His blood pressure is 150/90. His pulse is 120. He says it's been about 8 hours since his last drink. Over the last 5 years, he drinks about 8 beers a day. He does say he was admitted to a residential treatment program for alcohol once, but he has never seen an addiction physician. With prior cessation attempts from alcohol, he does become mildly tremulous. He denies prior blackouts related to alcohol, withdrawal seizures, delirium tremens, or other substance uses, including benzodiazepine. The ED team is concerned about his risk for developing delirium tremens or alcohol withdrawal seizures and is considering hospital admission. So let's start with understanding some epidemiology about how alcohol use has changed in the United States over the past 2 decades. This study compared data derived from surveys conducted in 2 nationally representative samples in the U.S. from 2001 to 2002, and then compared responses from 2012 to 13. The survey included responses from approximately 80,000 people. The table here demonstrates the prevalence of alcohol use, high-risk drinking, and a DSM-4 diagnosis of alcohol abuse or dependence across the time periods, as well as the percent change in the prevalence of each 3 outcomes. The authors defined alcohol use as any alcohol use in the past 12 months. They defined high-risk drinking as drinking 4 or more standard drinks on any day for women, and drinking 5 or more standard drinks on any day for men. Of note, DSM-4 is the former diagnosis criteria we use to diagnose alcohol abuse or dependence. Across the 2 time periods, we see a statistically significant increase in all 3 categories. Alcohol use overall increased by 11%, high-risk drinking increased by 30%, and alcohol abuse or dependence increased by 50%. It is worth considering how the COVID pandemic would affect these numbers today. Adverse childhood experiences and addiction are highly correlated. ACEs are traumatic experiences that take place before a child reaches 18 years of age. Examples of ACEs include neglect, domestic violence, sexual abuse, incarceration of a family member, or severe mental health problems in the family, including suicide. Chronic exposure to traumatic experiences in childhood lead to an inability to constructively cope with routine life stressors. Instead, what we see with people who experience ACEs in childhood are maladaptive behaviors to develop to cope with stress, including substance use. It's clear from numerous studies that ACEs are common across all sociodemographic backgrounds. They tend to cluster in family units, and they have a dose-response relationship with future mental and medical problems. In general, the risk of alcohol problems tends to be significantly higher for people who report higher ACEs than those who don't. So this study evaluated state-based cross-sectional survey data from 2012. The study included responses from 39,000 people across 5 states. Participants answered questions about past ACEs in childhood, including household mental health problems, suicide in a family member, household sexual abuse, substance use, incarceration, and violence in the home. Participants were asked about their current alcohol use, smoking, depression, and demographic information. After the authors controlled for age, race, marital status, and education, they demonstrated a 70% increase in heavy drinking among men who were exposed to 4 or more ACEs in childhood, and a 60% increase in heavy drinking among women also exposed to 4 or more ACEs. So before we get too far into this presentation, it's worth considering our patient, Mr. Smith. Not only is it likely that he experienced a number of adverse childhood events in childhood that contributed to his current alcohol use, it's likely he also feels many of the emotions depicted on this slide. People with addiction often report shame, stress, and feeling like they have an inability to cope, as well as significant depression and anxiety. All of these things lead to a vicious cycle of ongoing alcohol use. Many people with addiction have difficult relationships with their family and friends, and they also harbor intense shame. Finally, Mr. Smith has a higher risk of mortality relating to his drinking behaviors. I implore you to consider these complex issues when you provide care for your patients who suffer from addiction. Remember that your role as a physician is to provide compassionate care, to be non-judgmental, and be willing to recognize that your goals for Mr. Smith, which may include sobriety, may not reflect his goals. Please be empathetic with your interactions. Treat Mr. Smith with respect and meet him where he's at in his disease process. So let's talk about why people experience alcohol withdrawal. In a normal state without alcohol, neuronal excitability and inhibition are in balance with the NMDA receptors and GABA receptors in the brain, as we see depicted in frame A. In frame B, we see that with acute alcohol intake, there's an overall inhibitory state from alcohol's agonism of the GABA receptor, and the NMDA receptors are overpowered. The inhibitory state wins, and this results in the sedation many people experience with alcohol intoxication. In frame C, with chronic alcohol use, we see that NMDA receptors are upregulated to compensate for alcohol's agonism on the GABA receptors. This increased number and function of NMDA receptors is why people who chronically use alcohol are able to function in their daily life. Finally, in frame D, when alcohol is removed in a chronic user and is no longer stimulating the inhibitory GABA receptors, the upregulated NMDA receptors are left unopposed, which manifests as autonomic excitability, hypertension, tachycardia, the hallucinations and seizures, as well as DTs we see with severe alcohol withdrawal. So when considering Mr. Smith, what criteria are required for the diagnosis of alcohol withdrawal? Is it autonomic hyperactivity, tremors, insomnia, nausea or vomiting, hallucinations, anxiety or agitation, seizures, or is it all of the above? So in 2013, the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, was published. These criteria are used to formally diagnose alcohol withdrawal, and they include that the person has either stopped or heavily reduced alcohol, and they also develop 2 or more of the following symptoms, including autonomic hyperactivity, hand tremor, insomnia, nausea or vomiting, transient visual, tactile, or auditory hallucinations, psychomotor agitation, anxiety, or grand mal seizures. It's important that the patient also has their symptoms are causing them clinically significant distress or impairment in their daily life, and it's imperative to determine that the symptoms are not due to a general medical or psychiatric condition. So returning to our question, what criteria are required for the diagnosis of alcohol withdrawal? First, our patient must have significantly reduced or stopped consuming heavy alcohol use. Second, our patient must be experiencing 2 or more of the following symptoms. Third, the symptoms must be causing clinically significant distress or impairment. And fourth, the symptoms must not be due to another medical or mental health condition. It's important to distinguish severe alcohol withdrawal from mild to moderate alcohol withdrawal because severe alcohol withdrawal is associated with an increase in morbidity and mortality. Severe alcohol withdrawal is characterized by generalized seizures, delirium tremens, and is often refractory to standard benzodiazepine doses. Of note, delirium tremens is defined by hallucinations, disorientation with autonomic instability, which includes tachycardia, hypertension, hyperthermia, agitation, and diaphoresis. It's also important to distinguish delirium tremens from alcoholic hallucinosis. DTs occur in 3 to 5% of hospitalized patients with alcohol withdrawal and is associated with a 30 to 50% mortality rate. Alcoholic hallucinosis refers to hallucinations that develop within 12 to 24 hours of abstinence and then resolve within 24 to 48 hours. In contrast to delirium tremens, patients experiencing alcoholic hallucinosis are aware that they're hallucinating, and they may or may not report distress along with the hallucination. So next question. What risk factors, symptoms, or signs in your patient will predict severe alcohol withdrawal? Is it gender, a history of substance use disorder other than alcohol, thrombocytopenia, history of prior seizures, a systolic blood pressure of 140 or higher? Or do you think that individually none of these measures are sufficient to predict severe alcohol withdrawal? So this table presents results from a systematic review and meta-analysis of 50 studies that assess the predictive value of various signs and symptoms to identify which hospitalized patients were at risk for developing severe alcohol withdrawal. In this study, the authors defined severe alcohol withdrawal as experiencing delirium tremens, withdrawal seizures, or having clinically diagnosed severe withdrawal, as determined by the study's authors. Data from the studies were extracted and a meta-analysis was performed to calculate summary likelihood ratios. In order to interpret the likelihood ratios presented here, I'll remind you that a positive likelihood ratio of 2 increases the probability of the outcome by 15%. A positive likelihood ratio of 5 increases the probability of the outcome by 30%, and a positive likelihood ratio of 10 increases the probability of the outcome by 45%. So the results here suggest that having a substance use disorder other than alcohol use disorder increases the probability of developing severe alcohol withdrawal by over 30%, with a positive likelihood ratio of 6.4. History of prior DTs increases the probability of developing severe withdrawal by over 15%, with a positive likelihood ratio of 2.9. And having a blood alcohol level of greater than or equal to 200 or a BUN of greater than 26 on hospital admission increases the probability of developing severe withdrawal by over 15%, with a positive likelihood ratio of 3.5 for both of these variables. So clearly there are various individual variables that increase the probability of developing severe withdrawal, which then increases your patient's risk of mortality. The authors then went on to assess the positive likelihood ratios of developing severe withdrawal when using a composite of various outcome measures, including combined abnormal vital signs, reported history of previous seizures for alcohol withdrawal, and they included various published risk scales to describe alcohol withdrawal severity. So one of the severity scales that they assessed in this study was the prediction of alcohol withdrawal severity scale, so-called the PAUSE scale. The authors determined that the PAUSE scale performed best for predicting the development of severe alcohol withdrawal with a positive likelihood ratio of 174 and a negative likelihood ratio of 0.07. So if you remember, a positive likelihood ratio of 10 increases the probability of the outcome by 45%. So a positive likelihood ratio of 174 does extremely well to predict the likelihood of developing severe alcohol withdrawal in the syndrome, withdrawal syndrome. So we go on to ask, what variables are included in the PAUSE scale? So this table lists the questions included in the prediction of alcohol withdrawal severity scale and are easily applicable to our clinical practice. The questions include, first, have you ever consumed any amount of alcohol within the past 30 days, or does the patient have a positive blood alcohol on admission? If the person answers yes, then the following questions are asked of the patient. Have you ever experienced past episodes of withdrawal? Have you experienced alcohol withdrawal seizures? Have you experienced DTs? Have you ever been in any sort of alcohol treatment program? Have you experienced blackouts before? Do you ever combine alcohol with systemic depressants? Or do you ever combine alcohol with any other substances of abuse? The researchers who created this scale went on to identify if the patient's blood alcohol level was greater than 200 on admission, or if there was evidence of autonomic activity. In the study, the authors asked these questions to 403 hospitalized patients and then followed them over time to assess their progression to severe alcohol withdrawal, which they defined as the development of withdrawal-related seizures, or DTs. In this study, participants were grouped based on their responses to these questions and their associated scores. For example, patients who received a point for answering yes to one or two of these questions was then interpreted as their PAUSE score of 1 or 2. So the authors found that when a person scored less than 4 on the questions or the clinical criteria, the person was considered low risk for developing severe alcohol withdrawal. If they scored 4 or more, the person was considered high risk. The cutoff of 4 or more had a sensitivity of 93% and a specificity of 99.5%. The authors went on to conclude that the PAUSE score does an excellent job to predict which patients are at highest risk for developing severe withdrawal. Using this scale is useful when you are initially seeing a patient with alcohol withdrawal present to the emergency department. It will help inform your medical management with initial dosing of benzodiazepines or barbiturates, which will affect your patient's hospital stay, their morbidity, and mortality. So based on our history and presentation of Mr. Smith, and when using our PAUSE scoring tool, we recognize that he is at increased risk for developing severe alcohol withdrawal due to his past alcohol treatment, his blood alcohol level of greater than 200 on arrival, his pulse of greater than 120, and that he also reports he previously became tremulous when he attempted to quit alcohol. So let's go back to the question. What risk factors, symptoms, or signs are most likely to predict severe alcohol withdrawal? We now know that individually, one variable is not sufficiently sensitive or specific to predict severe alcohol withdrawal in our patients, and that we should consider the use of a scoring tool that includes a number of patient-reported variables and clinical variables to predict severe withdrawal in our patients. So moving on, Mr. Smith is admitted to the medical floor. And when putting in admission orders, you consider that it has been 8 hours since his reported last drink. When is Mr. Smith at highest risk for developing delirium tremens, since we know that this is associated with a 30 to 50% risk of mortality? Is it within 12 hours from his last drink? How about 36 hours from his last drink? Is it 4 days from his last drink? Or do you think he is at high risk until he is no longer having signs or symptoms of alcohol withdrawal? So this figure depicts time from last alcoholic drink to alcohol withdrawal symptom intensity. Time from last alcoholic drink in days is listed on the x-axis, and alcohol withdrawal symptom intensity is listed on the y-axis. What we see here is that people are at highest risk to develop DTs approximately 4 days after their last drink, but they're at highest risk to develop alcohol withdrawal seizures at about 1.5 days from their last drink. Tremors, irritability, and insomnia can last for more than 2 weeks, and some patients describe this post-acute withdrawal period to last up to a month, which puts them at prolonged risk to resume drinking. So according to the last figure, patients are at highest risk of developing DTs at 4 days from their last drink. They are at highest risk of developing seizures related to alcohol withdrawal about 1.5 days after their last drink. So as you put in orders for your patient, you consider which medications are the most evidence-based treatment options for the management of alcohol withdrawal. Is it oral alcohol? How about lorazepam, phenobarbital, diazepam, propofol, dexmedetomidine, carbamazepine, or gabapentin? So it's important to step back and consider how to manage patients with mild to moderate withdrawal symptoms who are not at high risk of developing severe alcohol withdrawal. You can use a validated scoring system to assess the patient's current level of withdrawal. Examples of this would include the CWA score, SOS score, or MIND score, and we will talk about these a little bit later. Next, you should assess your patient's risk for predicting severe alcohol withdrawal by using the pause scoring tool we just talked about. The addition of pharmacotherapy will prevent worsening of withdrawal symptoms when the patient's at home. Finally, it is absolutely imperative to verify that your patient has someone at home who can evaluate them for progression of withdrawal and bring them back to the clinic or to the emergency department if things progress. Evidence does support the use of home management of mild to moderate alcohol withdrawal as assessed by one of your validated scoring systems. It is safe to use benzodiazepines, carbamazepine, or gabapentin to manage alcohol withdrawal at home. This slide lists various short regimens you could prescribe to your patients for home management of alcohol withdrawal. For example, if you prefer to avoid sending your patient home with a benzodiazepine taper, you could prescribe a 5-day taper of carbamazepine. It is safe to prescribe a 3 to 4 day taper of a long-acting benzodiazepine as well. Of note, gabapentin tapers are safe for alcohol withdrawal and can be used for short-term to manage their withdrawal symptoms. They can also be used for a longer period of time to manage prolonged alcohol withdrawal symptoms, which we do see and include anxiety, insomnia, and irritability. It should be noted, however, that there are increasing reports of gabapentinoid-related use disorders. And so the use of gabapentin in patients that have highly addictive personalities should be considered and discussed with your patient. I do want to talk a little bit about ethanol for the treatment of alcohol withdrawal. Ethanol is not uncommonly used in ICU settings to manage alcohol withdrawal. It is important to understand administration of oral or IV alcohol has no proven efficacy, no accepted protocols for dosing, and there are known toxicities. Remember, ethanol has a short half-life. We metabolize 20 milligrams per deciliter per hour, which means that if your BAL were 0.2%, you would no longer be intoxicated in 1 hour. Using alcohol to prevent alcohol withdrawal means that a patient requires very frequent dosing to maintain intoxication to a level that would suppress withdrawal symptoms. Also, ethanol causes gastric irritation. It increases electrolyte disturbances, it can cause Wernicke-Korsakoff syndrome, and its use is associated with poor surgical healing. Finally, alcohol is expensive. Hospitals are not reimbursed for the use of alcohol since it's not considered a medication. Lastly, ethanol use for the treatment of alcohol withdrawal is not recommended by the American Society of Addiction Medicine. So when a patient is experiencing severe withdrawal, benzodiazepine and phenobarbital are considered first and second line by the American Society of Addiction Medicine. This table lists various benzodiazepines and phenobarbital, their onset of action, the duration of their effect, their half-life, and whether or not they break down into active metabolites. While no one benzodiazepine is more efficacious than another to treat alcohol withdrawal, longer-acting benzodiazepines are the preferred agent due to their longer suppression of alcohol withdrawal symptoms. Here you can see that diazepam has the fastest onset of action. It's about 1 minute compared to lorazepam, which has an onset of action about 2 to 3 minutes, and phenobarbital, which acts in about 10 minutes. A shorter onset of action for rapid control of autonomic instability is helpful to prevent stacking of medication. Diazepam also has a very long half-life, between 20 to 50 hours, which is useful for the prevention of breakthrough of withdrawal symptoms. Of all three agents highlighted, phenobarbital has the longest half-life, between 2 to 6 days. Lastly, both lorazepam and phenobarb do not have active metabolites, which is important to consider when your patient has acute liver failure or decompensated cirrhosis. It should be stated that phenobarbital should be used in caution in pregnancy and also with severe hepatic or renal impairment. All benzodiazepines are metabolized by the liver. Two commonly used benzodiazepines for alcohol withdrawal include chloridized epoxide and diazepam. These two medications are first metabolized by hepatic oxidation and then undergo glucuronidation. Lorazepam, oxazepam, and temazepam only undergo the second step of hepatic glucuronidation. If you'll remember, the P450 enzyme system contributes to oxidation of chloridized epoxide and diazepam in the liver. The first two phases of benzodiazepine oxidation is decreased in persons with liver disease and the elderly. In these patients, there is an increased risk for accumulation of active metabolites with incomplete oxidation of chloridized epoxide and diazepam, which can result in excessive sedation and respiratory depression. Because lorazepam metabolism is minimally affected by age or the presence of liver disease, it is the benzodiazepine of choice in these populations. Oxazepam is not considered a first-line benzodiazepine for alcohol withdrawal treatment because it has a slower onset of action than lorazepam. And temazepam is typically used as a sleeping medication and not used for alcohol withdrawal treatment. So take home for benzodiazepines, make sure to choose a benzodiazepine with a faster onset of action. You want a benzodiazepine that's longer acting, and consider the route of administration. For example, if your patient is not able to take oral medications, then prescribing chloridized epoxide will not be helpful. Finally, always consider hepatic impairment and age when deciding which benzodiazepine to choose. So let's move on to phenobarbital. It is useful to understand how benzodiazepines act on the GABA-A receptor as compared to barbiturates. Benzodiazepines potentiate the effect of endogenous GABA molecules at the GABA-A receptor to open the receptor and inhibit withdrawal symptoms. In patients with down-regulated production of endogenous GABA, which we do see with chronic alcohol users, benzodiazepine may be ineffective, leading to benzodiazepine resistance. In contrast, phenobarbital binds directly to the GABA-A receptor, allowing for direct inhibition of withdrawal symptoms. Thus, their effect on the GABA-A receptor is independent of the availability of the GABA molecule. To that end, there does not appear to be any patients who fail to respond to barbiturates when they're adequately dosed. It's worth mentioning that there are many opinions about the use of phenobarbital for the treatment of alcohol withdrawal. There are a number of studies demonstrating phenobarbital's safety and improved outcomes over benzodiazepines, including lower risk for intubation and shorter length of stay. Scenarios in which you may consider the use of phenobarbital include history of seizures or DTs, active DTs or severe withdrawal, if your patient has altered mental status, if they're at high risk for delirium, or if they do not respond to benzodiazepines, which we defined as a need for more than 10 milligrams of lorazepam in 2 hours or an equivalent dosing of other benzodiazepines. To date, however, the American Society of Addiction Medicine lists phenobarbital as second line to benzodiazepine for the treatment of alcohol withdrawal. Phenobarbital has a very long half-life, approximately 3 days, and successive doses will accumulate in an additive fashion. So once a therapeutic dose has been reached and the patient is no longer having signs or symptoms of alcohol withdrawal, little to no additional medication is needed to manage withdrawal. As such, phenobarbital will auto-taper and provide therapy for a number of days. Here is an example of a phenobarbital taper for alcohol withdrawal treatment. Alternatively, one could dose approximately 10 to 15 milligrams per kilogram per dose and repeat this dose every 30 minutes until symptoms have subsided. As I mentioned, the American Society of Addiction Medicine recommends that phenobarbital be used as an adjunctive medication with benzodiazepines for alcohol withdrawal treatment. Concerns related to the medication phenobarbital use are predominantly related to its narrow therapeutic index, which increases the risk for toxicity beyond that typically seen with benzodiazepines. Early signs of toxicity include slurred speech, confusion, ataxia, and continuous horizontal nystagmus. Later symptoms of toxicity include decreased consciousness, bradycardia, hypotension, coma, and respiratory failure. Finally, the use of phenobarbital should be avoided in patients with severe liver disease or in pregnancy. So some take-homes for phenobarbital. Remember, it binds directly to the GABA-A receptor and works in patients resistant to benzodiazepines. It has a very long half-life, which leads to auto-tapering for a smooth alcohol withdrawal experience. Phenobarbital is well tolerated in many patients without hepatic impairment, but careful evaluation of the patient's response to dosing must be assessed frequently to avoid lethal toxicity. Let's talk about propofol. So propofol is commonly used in the ICU to manage alcohol withdrawal. It is a sedative hypnotic agonist of the GABA-A receptor at a different binding site than where benzodiazepines bind. It does reduce glutamatergic activity through NMDA receptor blockade. It can be used in mechanically ventilated patients experiencing resistant alcohol withdrawal. It should only be used as an adjunct medication with benzodiazepines. And studies show that patients on propofol experience longer duration of mechanical ventilation and longer length of stay. Another commonly used medication is dexmedetomidine. It's a selective central alpha-2 agonist. It is an anxiolytic. It causes sedation without respiratory depression. It decreases the sympathomimetic response, including hypertension and tachycardia. It does decrease benzodiazepine requirements. That being said, there is no evidence that improves clinical endpoints such as mechanical ventilation or length of stay, and absolutely do not use this medication as a single agent. Always combine it with a benzodiazepine. Your patient could be experiencing alcohol withdrawal-related seizures with dexmedetomidine, and if you don't have a benzodiazepine on board, and you wouldn't know that. So let's go back to our case. You consider which are the most evidence-based treatment options for your patient. You quickly rule out oral alcohol, given its short half-life, challenges with dosing, and its systemic toxicity. You realize that you must consider your patient's severity of alcohol withdrawal, their hepatic function and age, and their past response to the use of benzodiazepines for alcohol withdrawal. So you decide to go with diazepam because your patient has a normal functioning liver and it has a faster onset of action than lorazepam, which will limit dose stacking. You decide you will use phenobarbital as a second-line agent if you need to due to your concern of its narrow therapeutic window. So how will you decide to dose the diazepam? Will you schedule the doses? Will you use a scale to assess withdrawal symptoms and then dose accordingly? Will you wait for the nurse to call you when the patient becomes agitated? Or will you give one big dose of diazepam and then send your patient home? So there are 3 dosing regimens used for the treatment of alcohol withdrawal. They are symptom-triggered, front-loading, and fixed dose schedules. We will review them all here in detail. So symptom-triggered is the most frequently used dosing regimen. In this protocol, medications are administered based on the patient's measured withdrawal symptoms. It does allow for dosing to be individualized according to symptom severity. It's been shown to reduce the risk of over or under treatment. It reduces the duration of treatment and inpatient length of stay compared to fixed dosing benzodiazepines. When using a symptom-triggered protocol, there are many commonly used validated alcohol withdrawal severity assessment scales that we use alongside it. Examples of these scales include the MIND scale, the SOS scale, and the CWA revised scale. Each scale has been studied and validated in various healthcare settings. The protocols include both objective and subjective measures, all related to alcohol withdrawal signs and symptoms. In short, the scales used in an institution tend to be cultural. This table compares 3 validated symptom assessment scales, MIND, SOS, and CWA-AR. MIND and SOS include more objective measures like vital signs, whereas the CWA-AR includes more subjective measures like tactile, auditory, and visual disturbances, as well as headache. CWA-AR has been reported to be a bit more cumbersome for nursing staff to score, as it includes 10 measures with a total of 67 maximum points, whereas SOS tends to be the easiest to score with 8 measures and a total score of 23. One benefit of MIND is that it includes objective measures like SOS, but it has also been tested across the ED, acute medical floor, and the ICU setting. All 3 scales allow for the determination of mild, moderate, or severe alcohol withdrawal, which then prompts dosing of medication. Let's talk about front loading. Front loading allows for the upfront dosing of a benzodiazepine or phenobarbital for patients at risk of developing severe withdrawal, or for patients in whom high doses of medication are needed for rapid control of symptoms. This is typically done in the ED when patients arrive and they're known to the hospital staff as experiencing severe alcohol withdrawal. Front loading has been shown to reduce the duration of alcohol withdrawal treatment, the development of delirium, and it's been shown to reduce the incidence of withdrawal seizures. Finally, there's fixed dosing. So fixed dosing of medications includes the use of a set amount of a medication that's administered at regular intervals. The medication dose amount, the frequency, or both are gradually tapered according to a set schedule. Fixed dosing is appropriate when you are unable to elicit subjective information from a patient, for example, reported anxiety, nausea, or delirium due to obtundation. It has been shown over or underestimate the amount of medication needed for withdrawal, which may lead to insufficient symptom control or oversedation. The American Society of Addiction Medicine recommends the following approach. In non-obtunded patients, use an approach that combines both front-loading and symptom-triggered protocols. In obtunded patients, use front-loading with a fixed dosing taper. So, you've decided on a protocol, but you are wondering how you'll dose the diazepam. Your patient is able to report subjective symptoms, and you're pleased to learn he was given 260 milligram dose of phenobarbital in the ED. So you'll use your hospital's preferred severity scale and dose the diazepam based on Mr. Smith's symptoms. So let's move on. You do notice that Mr. Smith looks thin and reports he isn't eating or sleeping very well. You begin to wonder what additional supportive measures would reduce adverse outcomes. Will you prescribe zolpidem for sleep? What about considering thiamine for the prevention of Wernicke's encephalopathy? Will you order double portions of meals with high-calorie shakes? Or are you going to make sure you turn the television on loudly so he won't feel lonely? So the American Society of Addiction Medicine recommends the following. They do recommend the administration of thiamine to prevent Wernicke's encephalopathy. They recommend IV or IM formulations over oral formulations due to improved absorption, and they recommend about 100 milligrams per day. High-dose thiamine is used about 500 milligrams IV daily if you suspect that your patient does have Wernicke's encephalopathy. Additional recommendations include administration of magnesium for hypomag, arrhythmias, or electrolyte disturbances, or if the patient has a previous history of alcohol withdrawal seizures. If your patient's phosphorus level is less than 1, you should supplement. and consider the patient's risk for receiving syndrome. Finally, you should consider folate supplementation in patients who are critically ill, because we know that chronic alcohol use is associated with hyperhomocysteemia. So you decide Mr. Smith is at risk for the development of Wernicke's encephalopathy, so you order thiamine supplementation before glucose administration. Well, good news, it's been a couple of days and Mr. Smith is no longer experiencing alcohol withdrawal, and he is inquiring about pharmacotherapy for the treatment of alcohol use disorder. He says his cravings for alcohol typically lead to relapse. Which medications here are not FDA approved for the treatment of alcohol use disorder? Disulfiram, naltrexone, acamprosate, or gabapentin. So disulfiram, or also known as antabuse, blocks the metabolism of acetaldehyde into acetate before it enters into the Krebs cycle by inhibiting the enzyme acetaldehyde dehydrogenase. Acetaldehyde builds up and causes violent illnesses in your patients, specifically vomiting, chest pain, or shortness of breath, or syncope. I've had patients tell me when they take this medication and they drink, they feel like they're having a heart attack and they're going to die. Not surprisingly, compliance tends to be low, and this medication is most effective when patients receive it as a directly observed medication. So sometimes it's administered in a methadone clinic, or if there's a family member that's willing to observe their family member take the medication, that can be effective. Extended release naltrexone, as well as oral naltrexone, are FDA approved for the treatment of alcohol use disorder. And there are many studies that have demonstrated its efficacy beyond placebo. Naltrexone acts by antagonizing the opioid receptor and is believed to blunt the pleasure people may feel with alcohol use. The study here was a randomized controlled trial where 82 patients were randomized to receive an injection of 380 milligrams of naltrexone, 190 milligrams of naltrexone, or they received a placebo injection. The patients were then followed over 24 weeks. Outcomes of interest were median time to first drink and maintain abstinence at 24 weeks. The authors reported that the median time to first drink was 41 days for the group that received the 380 milligram injection of naltrexone versus 12 days for the placebo group, which was statistically significant. The figure here demonstrates the rate of continuous abstinence at study end, which was 32% for the 360 milligram naltrexone group and 11% for the placebo group, which was also statistically significant. IM naltrexone is preferred over oral naltrexone because it is dosed once a month. Oral naltrexone is also highly effective when taken daily. However, as you would expect, compliance is less with daily dosing. Acamprosate is also FDA approved for the treatment of alcohol use disorder. It's thought to modulate the NMDA receptor transmission and GABA-A transmission to decrease glutamate activity during alcohol withdrawal. Thus, it has been studied to assess its effects on alcohol use and relapse. The study here was a systematic review and meta-analysis of randomized controlled trials that assessed the association between acamprosate on abstinence from alcohol. The primary outcome was the rate of abstinence from alcohol over the study period. The authors pooled abstinence rates between acamprosate versus placebo. The figure here depicts the forest plot and demonstrates that the pooled abstinence rate was 1.58 among patients who took acamprosate compared to participants who took placebo. Thus, people on acamprosate were 58% more likely to remain abstinent. It is important to note that acamprosate has very low bioavailability and is prescribed as 3 tablets taken 3 times a day, which affects compliance and thus outcomes. Gabapentin is FDA approved for the management of epileptic seizures and neuropathic pain. It's believed to indirectly modulate GABA's neurotransmission and glutamate synthesis and has been studied to assess its effects on alcohol use. The study here was a double-blind randomized controlled trial to evaluate differing doses of gabapentin versus placebo on alcohol-related outcomes among people with alcohol use disorder. The study included 150 people who were randomized to receive either 1,800 milligrams versus 900 milligrams total daily dose of gabapentin versus placebo. The study outcome were rates of abstinence over the 12-week study period and percent of no heavy drinking days, which were defined as 4 more drinks for women and 5 or more drinks for men. In this study, high-dose gabapentin improved rates of abstinence and percent of no heavy drinking over placebo. Abstinence rates were 17% versus 4% for gabapentin 800 milligrams, and no heavy drinking was 45% versus 23%. Both findings were statistically significant. Today, gabapentin is not currently FDA approved for the treatment of alcohol use disorder. Also, as I previously mentioned, we are seeing increasingly the development of gabapentinoid use disorders, where patients develop behaviors concerning for maladaptive use related to its use. There are case reports also describing increases in overdose among patients prescribed both opioids and gabapentinoids. To date, it is fair to say that the use of gabapentinoids still remains to be seen among various patient populations, and long-term use can be complicated. So let's return to our question. Which medication is not FDA approved for the treatment of alcohol use disorder? So gabapentin is the correct choice. As it is FDA approved for the treatment of neuropathic pain and seizures, it is not FDA approved for the treatment of alcohol use disorder. So Mr. Smith tells you he's currently taking buprenorphine for the treatment of opioid use disorder. Which medication should you prescribe for alcohol use disorder treatment that will not interfere with his buprenorphine? Disulfiram, naltrexone, acamprosate, or gabapentin? So we know that naltrexone is an opioid antagonist, so it cannot be used when patients are on methadone or buprenorphine for the treatment of opioid use disorder, nor can it be used in patients taking opioids for pain. We just discussed that gabapentin has been associated with an increase in risk for overdose when used with opioids. So that medication should be avoided in people taking full agonist opioids like methadone. I would support acamprosate as a good option, though it can be challenging in that it is a TID medication. Disulfiram has compliance issues and should be administered in directly observed situations. As I mentioned previously, it works well for patients that are receiving methadone in the methadone program, and when they receive their daily methadone dose, they can be dosed with disulfiram. So that concludes my talk. There are several people I would like to acknowledge for their support to expand addiction treatment in the hospital. Dr. Burden, the Division of Hospital Medicine, has been open and engaged with their involvement in expanding the addiction consult service. Our addiction medicine social workers, Michelle Kotloff, Doug French, Adrian Johnson, work tirelessly to provide treatment resources and link patients to treatment. Dr. Ernest has been fully supportive in my efforts to grow as a clinical researcher. And finally, my research mentors, Dr. Binswanger, Hopper, and Holtrop, have been instrumental in developing and implementing my research. I'll take questions if there are any.
That was a fantastic talk, really much appreciated.
Thank you.
Let me start off by just asking you a little bit about the differential diagnosis as it relates to alcohol withdrawal. When the diagnosis, when the diagnosis is not accurate, what are the competing diagnostic possibilities? And do individuals ever present with something as severe as meningitis and are misdiagnosed as alcohol withdrawal?
So the first question, I think what we do see not uncommonly are people that present acutely intoxicated with various substances. So for instance, methamphetamine, bath salts, other stimulants that can cause this adrenergic drive that we see. So how this manifests in patients is that you will treat their alcohol withdrawal and you do not see much improvement. So you'll start with benzodiazepines, you'll move on with phenobarbital, and if you really are not seeing an improvement in their symptoms, you have to go looking for other sources. Mm-hmm. And in terms of meningitis, I think meningitis, when it's severe, will probably present with higher temperatures, higher fevers. I think you're probably more likely to see them obtunded instead of so adrenergic. but again, I don't think that there's any harm with treating multiple causes, especially benzodiazepines are pretty safe. And so really you should keep your differential very broad.
Mhm. Good. What about the use of phenobarbital in alcohol withdrawal?
So I am a big advocate of oh, go ahead. What was that?
You think it's underused?
I do, yeah. Phenobarbital is a wonderful medication. I think the challenge comes with the concern of staffing patient to nurse ratios on the floor and the need to monitor the patients for signs of toxicity. And so, you know, in hospitals that do have a high ratio of patients to nursing, there is a concern that the patient could develop toxicities and die with phenobarbital. That being said, a lot of benzodiazepine use can cause respiratory depression, and these patients are also supposed to be monitored closely. So I think it's an institutional decision that includes the voices of nursing staff as well as physicians to talk about what's going to work, because what you don't want to do is create a situation where nursing staff feels overwhelmed and they're concerned that they don't have the ability to monitor their patients as well that are experiencing withdrawal, as well as all the other patients that they're caring for.
So if you were weighing deleterious effects of phenobarbital versus benzodiazepines, which would you err toward?
That's a good question. I mean, I do like phenobarbital. I think it works great. I think that when it becomes something that's done routinely in a hospital, people become more comfortable with its use, and you see some of these anxieties diminish. So I do think that the benefits of phenobarbital do outweigh the risks in patients with severe alcohol withdrawal. I would say that the benefits are diminished in patients that have less severe alcohol withdrawal, and those patients can be managed quite well with benzodiazepines.
Okay, good. And what about the encephalopathy that you see from withdrawal as opposed to the treatment of withdrawal? How do you assess?
Are you talking about with phenobarbital use?
Yes, with phenobarbital.
Yeah, so it can be tricky to delineate if your patient's encephalopathic because they're experiencing withdrawal and they're undertreated, or if they're encephalopathic because now they've been overtreated with phenobarbital. And you certainly can draw a phenobarbital level, but it's going to take a couple of days for your lab to return that value to you. So I think it's important for your physical exam, for instance, nystagmus is commonly seen as a sign of phenobarbital toxicity, and I've actually seen it, and it is quite impressive. So I would say if you are using phenobarbital, really rely on the clinical exam to assess whether or not they're over-treated or they're under-treated.
Okay. What's the role of race and sex in terms of determinants of treatment for either alcohol or opioid addiction?
So I think it comes down to insurance status, and I think it comes down to how states' Medicaid programs cover treatment. So in my experience working in Colorado Medicaid covers all sorts of medications for the treatment of any substance use disorder. The challenges come down to coverage of residential treatment. And so if you were to equate race with socioeconomic status and health insurance coverage, then I guess you could say patients that tend to be minorities do have lesser access to inpatient treatment. That being said, the availability of medications for the treatment of substance use disorder they're widely available for patients that have Colorado Medicaid.
So you don't think that race affects the practitioner use of various medications and interventions other than as it relates to affordability?
I really can't say with authority whether or not race affects physicians offering treatments to their patients. I don't know.
Mm-hmm. Okay, good. It might be a good area for future investigation. What about benzodiazepine sparing protocols, such as the use of clonidine? What are your thoughts around that?
The concern about the use of clonidine is that similar to Precedex, it's really just blunting the patient's autonomic drive. And so you're really, if that's what you're using as your marker of treatment of alcohol withdrawal, you're actually under treating the withdrawal. You're just dampening what you're seeing. And so I would not recommend the use of clonidine as a primary medication for the treatment of alcohol withdrawal. It's not an evidence supported or data driven use of that medication. I do think though, if your patient's adequately treated with benzodiazepines or phenobarbital, you really should see a reduction in the adrenergic drive, and you could add clonidine, but it's certainly not considered first line as an individual agent to manage alcohol withdrawal.
Okay. And tell us about the relationship between mental health disorders and alcohol abuse. If the underlying disease is the mental health disorder that's leading to alcohol abuse, how do you deal with that in the hospital prior to discharge or along with discharge? Since there's oftentimes a delay in someone getting out of the hospital and being able to access mental health resources.
So I think it depends on a number of things. It depends on the hospital physician's comfort of starting a new medication without being the physician that's going to follow them up. It depends on your social worker's ability to link patients to mental health treatment. And having social workers that can do that requires the support of a hospital that's going to pay for that person. I personally am very willing to start SSRI for a patient that is experiencing alcohol withdrawal and has co-occurring depression or anxiety. Also acknowledging that the effect of that medication probably isn't going to kick in for about a month. And I'm also lucky enough to have the support of addiction medicine social workers that can link patients to treatment. There are many places in Metro Denver that provide mental health treatment that accept Colorado Medicaid. So my personal practice is always to start an SSRI, although of course I would first ask the patient if there was a medication that worked for them in the past and then start that medication. I talked a lot about gabapentin. I do think gabapentin works well for this post-acute withdrawal syndrome that patients describe as absolutely debilitating, that lasts a couple of weeks to months after they stop using alcohol. And gabapentin does help calm that down and reduces relapse. Though, like I said, there is this sort of increasing risk of development of a use disorder related to gabapentin, so that needs to be considered. Ultimately, though, it really comes down to the hospital physician's comfort of starting a new medication. And, that's like incredibly important to consider for the wellness of both the physician and then the patient.
Right. Yep. I agree. But the consult service, your consult service, can certainly help with that.
Absolutely. That's what we do. Yep. Our goal is to be available to any medical team or surgical team in the hospital that's asking for help for their patient, and then Our social workers are phenomenal at linking patients to ongoing treatment when they leave the hospital. So please call us. We're happy to see our patients.
I think we'll end on that note. Thank you very much, Dr. Calcaterra.
Thank you so much.